person's obviously known to, I think all of us in the room. We've got Professor Paul Van Buynder, who we're shifting tact a little bit now, and I've heard he's a little bit unhappy that we've had an hour on infants and only a small fraction of time for older adults. So I'll make sure I get him up here a minute early so he's got plenty of time to tell us about protecting adults 60 years and older. Where should the focus be and how do we get there? Thanks, Paul.
Thanks, Paul. Thanks, Paul. And on behalf of the Immunisation Coalition, I'd like to apologise for the ageist approach that we've taken tonight. Paul Effler and Peter Richmond have done an amazing job in WA in actually getting us a combined program of maternal vaccination and neonatal monoclonal antibody that's actually solved the problem on RSV in children. So, I apologise that we took the first hour to talk about something that's fixed. But we are going to try and very briefly, in the short time they've given us, talk a little bit about RSV in older persons. So these are my disclosures. RSV is a disease of all ages, and you've seen some data on that already. It's not just a disease of children. It goes to people all the way through life. Very poor protection post-disease. And so that we actually have older adults who are at very high risk of severe RSV infection. Very difficult to actually pick it in older persons. They present with cold-like symptoms to start with, similar to many other pathogens, but can get with exacerbation of comorbidities, cardiovascular complications. A good paper recently on the severe effects of RSV on people with cardiovascular conditions, hospitalisation, and a mortality that's actually worse than the mortality in children. So the risk factors in older adults are A, being old. I'm 68 going on 70. They tell me that my telomeres really don't function anymore, that between immunosenescence and inflammaging, I have very little protection unless I get lots of vaccines. I take 8 tablets every morning, so I suspect that I've probably got that comorbidity risk that people are talking about being a risk. And adults with a weak immune status really involves just about everybody of an older age. So let's look at some data. We didn't really make RSV notifiable until 2021, so we don't have great data, particularly in older persons in Australia. This is some data from a paper from the US. It looked at paediatric versus older persons RSV disease. It said that hospitalisations were probably anything up to double in older persons than they were in children, and deaths were close to an order of magnitude more in older persons than they were in children. So I think there are 3 reasons for having a vaccine. One is you believe the disease is significant. 2 is you believe that vaccine protects. And 3 is you believe that vaccines are safe. And I think what we're seeing with the data available, at least from elsewhere, is that this is a disease that is significant for older people. These are some of the estimates, and this paper was referred to a number of times by Hannah. The median length of stay for hospitalisations is about 6 days. 59% of RSV-associated in-hospital deaths occur in adults over 65. And if you're admitted, 1 in 20 people admitted as an older person to hospital with RSV passes away. So these are some estimates comparing RSV to flu. Everybody agrees flu is bad for old people. Not that anybody wants to get vaccinated anymore, but the hospitalisation rates are about equivalent for flu and RSV, and the mortality over 4 different studies was about 120% for RSV over flu. These are a number of comparisons again of influenza to RSV the length of stay was longer in RSV. The rate of pneumonia was significantly worse. RSV is actually a more significant precursor to the likelihood of developing pneumococcal disease than influenza is. And so this is not just a matter of RSV itself, but it's also its interplay with other secondary bacterial pneumonias that tends to occur with RSV. The survival rate was 1.3 times worse in RSV than with influenza. And this is one of the really most important things. The role of immunisation is not to protect disease. The role of immunisation is to maintain functional capacity. What older people worry about is not whether they get the flu for a week or not. They worry about being increasingly frail, ending up in assisted care. They worry about the impact on their cognitive status. And a sub-study of US data looking at RSV disease showed exactly what we see with influenza. Pneumonia and other respiratory conditions are the third largest cause of catastrophic disability in people, and that's disability that moves you at least 3 levels on the frailty scale. And so people get admitted to hospital and then they don't go home. They clog up a bed while we try and find an aged care home or an assisted living facility for them. So up to 25% required professional home care, and most of the ones that didn't were readmitted to hospital within the next 3 months. So what do we do about it? I think what we agree is that this is a nasty disease for old people. We've already heard a lot from Hannah about the fact that our undermenstruation is huge, that we really don't test older people for RSV most of the time. There's no specific treatment, so it's supportive care for people with acute infection. And all we really have for this is recently a whole range of very effective vaccines to protect older persons against RSV. And so there's 3 that I want to briefly talk about in the paucity of time that the Immunisation Coalition allocated me. Arexvy from GSK, Brisvo from Pfizer, and one which you may not have heard of, Mrezvia from Moderna, which is licensed in Australia but is the one of the 3 that's not actually available for use here. They're all licensed for older persons. They have slightly different indications based on studies. None are currently available on NOP, although one of the 3 looks like it might be soon. And like all good vaccine company studies, they had totally different study designs, totally different definitions of what is a severe disease or an even more severe disease, and totally different ways of looking at when they gave the vaccine and how they actually measured it. One's now starting to present data after 3 years. One studied it for 18 months and said that was 3 seasons, and so good luck trying to work out the difference between one and the other as we go through. So I'll go through these relatively quickly. Arexvy is one of the ones that is available here for older persons. It's actually now got an indication from 50 up rather than 60 up that the others have. It's one of the pre-fusion antigens, as they all are. It's linked to their AS01 system, which worked astonishingly well with Shingrix, that we've been using it for the last couple of years on the schedule in Australia. As that says there, it's now actually for people over 60, but for people with another condition over that complicated process. They've been going for 3 seasons now in their phase 3 trial. Some people had the single dose and they're monitoring that the whole time. Other people get a boost. Another group were just getting placebo. I'm not going to go through all these because they're different for each of the studies, but they have a definition as what's acute respiratory infection if you've got 2 symptoms or 3, then your lower respiratory tract disease. It's severe if it's something different. And this sort of stuff you'll see throughout these slides. First year data, 80% or 90% if we're talking about their definition of severe disease. It drops off in the second year for people who don't get a boost, but it's still somewhere between 2/3 of people who have lower respiratory tract disease and probably close to 80% for people who have severe disease. This is, again, looking at different age groups, and you can see that in fact the severe disease in older people it works even better and doesn't drop off that much in the third year. These are some other data that they've presented, and again, really what we're saying is that this particular vaccine works really well in stopping disease, works incredibly well in the first year for stopping severe disease by their definition, drops off a bit in the second year, and their early data says it's still pretty good in year 3, but their early data has not actually produced anything for the severe disease. That's only for the other start at this stage. So in summary, this stuff works really well. It says it has a well-tolerated, acceptable safety profile. Most reactions are mild to moderate. And the second dose, for those people who get a second dose in the second year, has the same sort of reactogenicity as the first dose. Moving on to Abrysvo, which is a non-adjuvanted, bivalent, so it has RSV A and B vaccine. And again, what you're starting to see there is that for lower respiratory tract disease, it works at about 80+% for 1 year, 2/3 effective for 2 years, and for severe disease is even more effective again than for any disease. It's a unadjuvanted bivalent vaccine. It's available for 75 years old and above here, Indigenous above 60 years, and adults above 60 years with a risk factor for severe disease. Their particular study enrolled tens of thousands of people. This is their particular design, which looks a little bit different to the previous one. Again, they had endpoints which were a little different to the endpoints for Arexvy, but in the end, what they're showing there is that with Abrysvo, they had very good protection against severe disease and good protection still against non-severe disease. Their serious adverse events showed a fairly good profile, although they did have some increase in severe reactogenicity events, but we're still talking about 1%, and certainly not something that would put people off. This is one thing that I think is important to mention. One of the reasons I think that we had a restriction in our 60 to 75 year recommendations to people only with severe disease was that in the early analysis of study trials, there was a signal that suggested that there was a GBS issue in the phase 3 trials. Numbers weren't big, but we didn't really expect numbers in the sort of number of people that we had in the trials. There's been a big review by both the FDA, CDC type group. This, of course, happened prior to the recent abolishment of CDC, ACIP, and everything else that's unpalatable to RFK and Donald. There's summary from the CDC, the ACIP, which was a body that used to exist in America, was that with Abrysvo we had about 9 excess GBS cases per million. With Arexvy we had about 7 excess GBS cases. So this actually said there probably was a signal from the phase 3 trials. But I like this statement. This is the UK statement about it. It says, while both infection and vaccination carry a minimal risk, the overall incidence remains low in both scenarios. The benefit of RSV vaccination in preventing severe illness in high-risk populations continue to outweigh these rare risks. So I believe this should be recommended to every older person. I think because of the fact that there are statements about this, they should be told that there is a very low risk. We're talking about less than 1 in 100,000, but the risk itself is much less than the risk with RSV, with RSV itself, and it's far outweighed by the benefit you'll get by being vaccinated. So while I don't think we can ignore it, and I think it is in the statement, and you need to share that with your patients, it needs to be in the context of, but you are going to get much more benefit by getting this than worrying about the risk. So the last one I want to briefly touch on is the mRNA-based vaccine, which again looks at stabilised pre-fusion protein. The antibodies cross-react with both RSV-A and RSV-B. It uses the same lipid nanoprotein as used in the Moderna COVID-19 vaccines. It is now approved in Australia but won't be available for this winter, and whether it's available next winter will depend a little bit on what's happening with their plant in Dandenong and the second phase of the TGA approval, which is not through yet. Outcomes based on whether or not we're going to get disease. They actually enrolled all year round, so they enrolled in summer and winter and gave vaccine all year round. They've been going for 18 months, but they're reporting 3 RSV seasons in the way that they've actually done theirs. And you can see that really what we're seeing is pretty well equivalent to what we're seeing with the others. It's about an 80% protection against both lower respiratory tract disease and severe respiratory tract disease. They're saying vaccine protection continued through the second and third season, which were much higher incidence than the first two, and they're saying through that end of the third season they're still getting 50% vaccine. No cases of acute demyelinated encephalomyelitis. No safety concern with GBS. So maybe the GBS signal does not apply to these two after the issues of pericarditis, myocarditis in younger males, largely with their COVID vaccine. They didn't see any of that so far with their mRNA RSV vaccine. So, to reduce RSV disease, we need vaccines with good effectiveness and safety. I think I can make a case based on the data that we've got from the 3 companies that they have good effectiveness. I'm not sure I can make a case as to what the duration of protection will be, whether we're talking boost in 2 years, boost in 3 years. But I can say that we need to use them. Vaccines do not protect people. Vaccination protects people. That having lots of these good vaccines will make no difference if we end up not dealing with our current problems with vaccine apathy, decreasing flu rates and all of the rest of it in these. And this is the problem, that on one side we have good advice from physicians, easy appointments, government programs, fact-based information to be out and get vaccinated. On the other side we have misinformation, difficult to get an appointment, unanswered questions, no reminders, and the United States of America, whatever the hell is going on in that country at the moment. Did I stick to time? Thank you.
All right, so we've got some time for questions, and thanks to our American colleagues online who have just so I'll start with an online question. So if an older adult has had RSV and it's confirmed, should they still get vaccinated, and how long after?
Look, I don't think we have any data on that at all from the point of view. What we do know is that you do not get good protection after clinical RSV, and we also know that the protection you do get does not last. If someone had RSV in my practice, I would not give them this season's RSV vaccine, but I would certainly bring them along next season to try and get them vaccinated as well. Look, I think one of the challenges we're going to find until this gets on the NIP for all of these people is that this is not flu vaccine from a cost perspective. We did very well in clinical practice making Bexsero for children a family issue. I know you're a single mother, I know you've got 2 kids, I know that you are balancing school uniforms with putting food on the table, but maybe grandpa or grandma will pay for your Bexsero to help protect their children, or maybe you've got somebody else in the family. If you've got an old person, maybe they've got a son that's got a good job, or a daughter that's a lawyer, or somebody who works for Sanofi or GSK, and they can actually kick in and get this vaccine for you. Because I think it's really important. It'd be disappointing if the uncertainties about duration of protection or whatever it means it's not on the NIP for a while, and that we're not getting people protected.
I think there's a lot of talk about combination vaccines, and if you just wouldn't mind telling us about co-administration, whether you think it's a good idea to do maybe COVID flu all at once, and what your thoughts are on combination vaccines maybe coming?
I don't know if many of you actually spend a lot of time looking at what's in the pipeline at the moment, but I had to upgrade my computer so that I could actually keep a record of what's happening in the vaccine pipeline at the moment. I'm pleased to say that I was the recipient of a phase 1 Sanofi human metapneumovirus RSV parainfluenza A vaccine 9 months ago, so I'm hoping to have been protected against all 3 of those through that trial. There are huge amounts of combination vaccines that are in the pipeline. I suspect the closest one to being available to us is actually the Moderna COVID flu combination, but I am told by the company that even that will not be available for 2026, that we're talking about 2027 before something like that would be available, and before I'd be wanting to use that, I'd want to be comfortable that the flu combination part of that was actually going to be as good as one of the enhanced vaccines that we're using in older people now, the adjuvanted or the high dose in the 60 to 64. So from the point of view of using more than one of these at the one time, the only time that we've really looked at this and split them up was when we really didn't know what would happen with COVID side effects. And so we said, don't give flu vaccine within 2 weeks of a COVID vaccine, but that wasn't because we were worried about safety. That's because we wanted to find out exactly what was happening with the reactogenicity. We're now saying feel free to give both at the same time. We did have some debate about whether 2 adjuvanted vaccines should be given at the same time, whether that would increase their reactogenicity. I think there is still a feeling that maybe we should split 2 adjuvanted vaccines, so you're talking about a Fluad and a Rexy, but if you believe the person will definitely come back in a week or 2 to get the second one, good. If you don't believe that's the case, give both at the same time. And none of these are live, so we're really not worrying about interference with any of these. Yeah.
Question. I presented on older persons, how can we do it better this morning. Back when I was a young girl and started in public health, where there was flu and pneumococcal, and that was it. Soon we're going to have about 6 vaccines for over 65s. If we're going to introduce another vaccine, and this includes RSV, can this be a coordinated approach, please?
Oh.
Because, I'm sorry, because...
Sorry, have we got a representative of the federal government?
No, but can we advocate for that? We've got a lot of loud voices here, but is that something we can advocate for? Because look, it's not happening.
I think it's... I was serious about saying this is an ageist meeting. This always is, you know. Every day I get up and I check the changes to ATAGI, looking for the geriatrician on ATAGI, and I never seem to find them. It's full of paediatricians and immunologists and really, really clever people who aren't old enough to worry about people like me. And so, we need older people to get 6 vaccines.
So those kids are vaccinated 90 to 95%. Older persons are sitting at what, 50%, 60%?
Well, I think we're almost at 60% for flu again. We're nowhere near that. And I mean, some of these are free.
Yep.
You know, our coverage rates for Shingrix is probably 38-40%. It's a free vaccine. Our coverage rate for a conjugated pneumococcal vaccine is unacceptable as it used to be for polysaccharide vaccine in that age group. But there isn't actually any process out there that's saying, here's what we're doing. With a enormously effective fellow called Michael Woodward, who's a geriatrician, we ran a masterclass for geriatricians last year to try and actually get people who continuously work with these older patients to be more of a person interested in that rather than dementia and frailty and all the rest of it. And we're doing another one next year, and we're really keen to try and get them and rheumatologists and all these other people saying these people need all of these vaccines because they're on a biologic or they're on something else. But the problem is I send lots of notes off to the Minister for Ageing and he hasn't responded yet to any of them. We need to make this something that says we're actually going to have a whole of life policy that's more than just, yeah, it's available. You know, it can be given to these 6 people, even though ATAGI recommends it for 4 million. You know, so that there's a whole range of things that say you need to have the vaccines available. You need to use them, but in order to do that, you need to have access for the people, and that brings up aged care and what's happening in aged care. You need to have them funded. You know, it's got to be a process that says, okay, we've got Shingrix, we've got flu. For some reason, you can't have pneumococcal until you're 70. You know, so I'm holding out for that. I'll be 70 at the end of next year, so I'll be able to get a pneumococcal vaccine. And, you know, we don't give pertussis. There's a mortality associated with pertussis in older people. There's a whole range of things to do with that. But thankfully, we don't have to worry about our children because they're 95% vaccinated. And we have lots of Commonwealth groups full of paediatricians who say we'll keep protecting them, and flu, pneumococcus, RSV, it's all God's little helper for you old people.
I think I'll catch up with you out of session tomorrow.
One more question.
Hi, I'm Monique from Aspirin. We actually do vaccine effectiveness estimates on flu, and we're trying to do it on RSV, but unfortunately don't have enough data because of the low numbers that are coming through. But yeah, really interesting to hear how effective the RSV vaccine is and how long it's effective for. I was just wondering if you could comment on just regarding 2 years compared to the flu vaccine, which we know is a much less effective over time. Is it the virus or is it the actual vaccine that's the issue there with flu? Or is it just, is there any serosurveys that show that, like, if someone was infected with RSV, are they then protected for a lot longer after compared to the flu?
They're very different viruses. I think that's the first thing. Influenza has different strains. One of the influenza strains is much more mutagenic than RSV and the other flu. I mean, H3N2 is much more likely to drift in a given year. And so it's more of a problem with us trying to protect them. We started with a whole cell vaccine, I don't know, 60, 70 years ago for flu. We've progressed to purifying them and doing things to decrease reactogenicity. In a bad drifted H3N2 season, flu as a TIV or QIV did not work. You know, we have years where the effectiveness was minus 13% or something. What I'm comfortable is with our current enhanced influenza vaccines, they work better for H3N2, they work better against heterogeneous strains, and they give us better protection throughout the season, whereas before that we used to look at 8% decrease per month with flu effectiveness, flu vaccine effectiveness for H3N2. So we now have vaccines that I'm confident can give us 50, 55, 60% protection for older people, particularly against hospitalisations, protecting them losing activities of daily living. And so, they've got better, but they're very different viruses and very different vaccines from the point of view of the technology and all of the rest of it. And flu vaccines are really in a state of change. There's a chance that we'll get recombinant vaccines in the next year or so. I think this is our last year of egg vaccines in Australia for flu. We'll have cell-based vaccines next year, coming out of Tullamarine instead of out of Parkville. So I think there's a lot happening there, but we certainly have a ways to go. But I get back to vaccination protects people, not vaccine. And if you look at our vaccination rates, this year is less than last year. Last year was the worst for ages. We're running at 60% when we used to get 80% for our older persons. So we actually need programs that say we need to actually stress how bad these diseases are and how important it's been. Brisvo in pregnant women has been pretty exciting because what we're seeing is data coming out saying that we're looking at 60% already, so that they're listening to that. Flu vaccine in pregnancy is probably half that. And there's still a lot of clinicians who don't believe in flu vaccine, but we need to actually sell the message that influenza, RSV, COVID, HMTP are all really nasty diseases in old people, and they have consequences that are more than just you hospitalise, you go home, you live or you die. They have severe impacts on functional capacity. And so we've got to get serious about selling these messages because we're not doing that at the moment. And I think that's really the critical thing that we need to do moving forward. Thank you for the opportunity to talk beyond my time.
All right, yeah, thank you very much, Paul. It was a fantastic talk. So we might just have a few quick minutes off to get ready for our panel discussion that will be up in a moment.